Hello everybody and welcome to this PCR webinar which is sponsored by Shockwave Medical and it's dedicated to the treatment of complex calcified lesions. The main goal of this webinar is to keep the procedure simple and safe. And the objectives of this webinar are, I hope, very clear. We want you to learn about the diagnostic tools and the appropriate planning of modern PCI in calcified lesions, to learn how to recognize challenging cases and integrate the fluoroscopic aspects with intravascular imaging, and to discuss together about how to perform the procedure step by step, guided by safety and efficacy. To reach these objectives, it's a pleasure to have together with me in the Europa studios two young but expert and very gifted operators. Dr. Claudia Cosgrove. Hello, Claudia.
Hello.
She works in London at the St. George Hospital. And Dr. Claudio Ungureanu.
Hello.
Hello, Claudio. He works in Belgium at La Louvière, at l'Hôpital de Jolimont. And that being said, I underline that the main goal of staying together these next 60 minutes is to share with young operators how to deal with complex calcified cases that are naturally always hiding difficulties and problems in our daily practice. So there is no better way to discuss how to do our job than doing the job. So the first case will be presented by Claudia. Please, Claudia.
Thanks, Flavio. So this was a case we performed at St George's in London recently when I was on call. In fact, my fellow performed the case with me assisting. So this was a 66-year-old man who presented with an anterior STEMI. He was a heavy smoker and had been for many years, but had no other significant medical history. He had transthoracic echo in the emergency department, which you can see is consistent with an LAD territory infarct with apical hypokinesia. And he came to the cath lab for a primary PCI. So you can see the right coronary artery is dominant and was free of disease. And, sorry, I'll just go back one. And the circumflex also is relatively free of disease. And unsurprisingly, the culprit is an occluded proximal left anterior descending artery. So this was wired and pre-dilated with a 2.5 millimetre semi-compliant balloon. And this restored flow in the artery.
So that's the first good piece of news.
Yes.
I mean, the most important thing is to open the vessel as soon as possible with an appropriate TME3 flow. I guess that after this first balloon inflation, the patient relieved the pain and the ST elevation improved. You have a nice flow distally. But of course, I'd like to know how you evaluate this lesion. How much calcified is, on your opinion? It seems that the 2.5 balloon did a good job, but do you consider this as a heavily calcified, moderate, or slightly calcified, Claudia?
I think you can see on the angiogram on the right that there's at least moderate calcification as based on the angiographic appearance of calcium before the dye enters the artery. I think that 2.5 millimetre balloon, although it's undersized for the vessel, you can appreciate that it's underexpanded. So I'm suspicious at this point that there's at least moderate calcium that's going to need to be modified before we can put a stent in this vessel.
But most of the time we are concerned about dilating aggressively the lesion in acute MI because of the risk of low flow or no reflow. So would you go directly with a stent after this 2.5, or do you think this needs better vessel preparation?
I think that's the temptation in a STEMI, is to directly stent because we worry about distal embolization and no reflow. But I think we often do see a lot of calcium in STEMIs, and we need to prepare the vessel adequately, otherwise we're not going to get a durable result. Fortunately, this wasn't a heavily thrombotic lesion we can see so far, so we do have a little bit of time to assess the vessel more thoroughly, and I think perform some further balloon-based calcium modification.
So that being said, which was your next step?
So next we did some intracoronary imaging to better assess the degree of calcium, the pattern of the calcium, and also the vessel size. So we went on and did an IVUS run. Mm-hmm. So here we have the IVUS pullback playing, and I've just highlighted a couple of points of interest throughout the vessel. So you can see that distally there was this area of eccentric calcium, almost a calcific nodule at the site of a large septal. Proximal to that, there was an area of concentric calcium, almost a 360-degree ring of calcium. So there's different distributions of calcium. On the IVUS pullback, we can see that really there's quite extensive calcium throughout the whole vessel, or throughout the whole proximal and mid segment. And that image on the top left is the ostium of the LAD, which you can see has quite significant plaque burden, and so we really don't have a landing zone anywhere in the proximal LAD, and we realised that we would have to come back into the left main coronary artery. So first of all, we pre-dilated further with a non-compliant balloon, a 30 millimetre non-compliant, and up to a relatively high pressure of 16 atmospheres. Mm-hmm.
Did you size this balloon angiographically or according to your IVUS observation?
A bit of both, I suppose. I think it's still probably a bit undersized for the vessel, as we'll see, but we're being a bit conservative. I think still you can see angiographically that this balloon's underexpanded as well.
Claudia, you said angiographically your evaluation of the severity of the calcium was moderate. Mm-hmm. That this idea changed after you have seen it from inside with the IVUS?
Yes, I'd say I've upgraded it to a severe in that it's extensive. There are areas of nodular calcium, concentric calcium, and it's calcium that needs to be modified further. So I think, yes, I think on the IVUS, we'd say it's severe calcium. Okay,
Claudio, having seen this angiographic and IVUS image, and now you see this 3.0 balloon, I mean, I want to know also your opinion. Is that a properly expanded balloon? Would you go with the stent and outright stride forward? Or you think you still need to work a little bit on lesion preparation?
From the scene appearance, it didn't seem to have a nice expansion of the 3 millimeters balloon non-compliant. Just to remember, it was a 16 atmosphere. I would prefer sometimes to do a stent enhancement on the balloon. Sometimes we see really well the calcified lesion next to the balloon, and also we can evaluate in a better way this expansion. But seeing this result, I would maybe assess again with IVUS and maybe choose the strategy or the therapy to prepare well this lesion and to gain more compliance of the vessel.
Okay.
Okay, well, that's exactly what we did, Claudio. We went on and did another IVUS run to assess the effect of the NC balloon. And really it had an inadequate effect, I think. And you can see on the right, again, that area of concentric calcium is almost barely modified at all. It's still a intact ring of calcium. And so I think we knew that we needed something else at this stage.
Yeah, it's very clear that you have 360 degrees calcification. This normally creates problems. Not for putting the stent. I think the stent will navigate easily, but then the expansion might be, non-satisfactory.
Exactly.
So would you go with higher pressure, bigger balloons? Are you concerned about developing low flow or dissections?
Yeah, I think, that would be an option, I think, is to go with a larger balloon at higher pressure, but I do worry about causing large dissections, particularly in an acute setting in the STEMI situation, and of course, again, the risk of no reflow that we've mentioned. Mm-hmm. So we went on and used lithotripsy in this stage. So we used a 3.5 millimetre shockwave balloon, and it was the C2 plus balloon, which has 120 pulses per balloon. And that was particularly useful in this situation where we had quite a long segment of calcium in the proximal and mid vessel. So we were able to spread those pulses out between the various areas of significant calcium. So from that area of calcific nodule up to the concentric area. And one thing I do consider is whether these repeated 10-second inflations might cause hypotension or ischemia in a patient who's already can be a little bit unstable in a STEMI situation, but actually the patient tolerated this very well.
But in that case, let's suppose it's a more proximal or even a left main, can you stop? I mean, instead of waiting 10 seconds for 10 pulses, can you do it 5 or 7, stop and restart?
Of course, yes. You can break them up, you can bring the balloon back into the guide, have a rest, wait for the blood pressure to come up, and then deliver some more pulses. So you don't need to deliver it all in once.
I like your choice because probably is the easiest and the simplest, and this is what the webinar is about. It's just inflating a balloon for what I have understood. But I have a couple of questions. First of all, for instance, did you consider using rotational atherectomy in this case?
I didn't think that it was necessary. I mean, I think that that's certainly a consideration, particularly where there's a bit of bulky nodular calcium. There's potential risks of using rotablator in a STEMI situation. Again, we worry a bit more about no reflow, perhaps. It's also maybe a little bit more onerous to pull out the rotablator in the middle of the night in a STEMI when you might have less support around. Although there was concentric calcium, the lumen area wasn't severely stenosed and balloons were crossing, so perhaps there wasn't as much of a need for rotablation in this
I agree. Since you managed to cross with a 3.30 balloon, I mean, probably you don't need rotablation. But you have mentioned that your shockwave balloon is called C2 plus. I mean, I have never used C2 plus. Is that a new balloon? It's a new shockwave?
Well, I think it's similar to the old balloon, but it has more shocks. So as opposed to the 80 shocks in the old balloon, this one has 120 shocks available to use. But in other ways, it's very similar.
Is it already available? Do you have it already? Are you using the C2 plus? Because I don't have it in Verona. I mean, I am a bit jealous about you having it and me not.
Well, a little bit lucky. We just had the opportunity to use a couple of times this balloon, and it's really an important advantage because sometimes we just don't buy only one catheter. We just buy 120 pulses, and before we buy both only 80 pulses. I think it's a huge step further in the treatment of this disease, which need a lot of pulses to be effective.
Okay, so this has 120 pulses. The previous had 80, so you can use the same balloon probably in a longer tract. You don't need to use 2 balloons. Or in case you have resistant stenosis, that it's no opening properly, you can insist always 10 seconds per cycle. Is that right?
10 pulses per 10 seconds per cycle.
Did you use all the 120 pulses there?
We did. It was quite a long segment, I think. So 120 was a good number.
Curious to see the difference in between what you obtained with the high pressure balloon you used before and with the shockwave. So I guess you repeated the intravascular imaging, Claudia?
We did, yes. So here's the pullback again. I think the first thing to say is there's a little bit of dissection, but there isn't extensive dissection. So I think that's probably one advantage of using the shockwave balloon in this situation. It's very safe in that way, not causing large flow limiting dissections. It's been very effective in this area of concentric calcium. So you can see on the top was the intact ring of concentric calcium before the shockwave, and below we clearly got multiple fractures in that ring. So I think this is a excellent result in this segment. In that area of eccentric calcium, it's a bit harder to assess the effect of the shockwave or any balloon-based therapy, I think. There are some reverberation artifact visible in the post-IVL IVUS frame of that eccentric lesion. I think overall, after this, we felt that there was ready to stent, and we'd modified the calcium as much as we could, and that the compliance of the vessel had been restored.
Okay. As you both know, our webinar is live and it's open to the questions coming from the colleagues that are attending. And I see that questions start coming after only 10 minutes of your presentation, which is very good. It's a very interesting question from Sayan Narayanan, who is asking, what do we have to look at the IVUS to understand that the vessel preparation is sufficient and we can go with a stent, or that we have to work further on that? This is a very important.
Yeah, I think it's a good question. And certainly when we see those fractures, that's very reassuring. And when we see multiple fractures in a previously intact shell of calcium, then we know that that vessel is going to be more compliant and ready for a stent. I think it is harder when you have eccentric calcium to know when the vessel is ready, and I think it's probably also important to use the intracoronary imaging in conjunction with the angiographic information. So perhaps taking a non-compliant balloon after you've used something like the shockwave to see that it expands symmetrically and fully, because I think that gives you a lot of reassurance that the vessel is now, the calcium's adequately modified.
So it's fractures, then you can also assess the internal minimal lumen diameter. I mean, you see that from before to after the vessel lumen gets bigger.
Yep.
And now you are thinking about implanting the stent, but of course it's a long lesion, it's calcified, you have, I have seen some calcium on the OCL LAD. Are you planning to go to a spot stenting where the vessel was occluded, or you are aiming to treat from healthy to healthy and going with a long stent from the left main, which is coming into your mind after this intravascular and also the angiographic images that you got from the beginning?
Really, there was such extensive plaque from the mid-vessel back to the ostium of the LAD that there really wasn't any, disease-free or low burden of plaque in which to land, and so we needed to come back into the left main. So we will need quite a long segment of stent, but hopefully that will give a more durable result by landing in disease-free vessel.
Mm-hmm. So you are ready to stent? Do you feel that vessel preparation is enough? The stent will navigate and will expand?
Yes, at this point we did think that.
Okay. Any concern about dissections, thrombotic images in this?
No, I mean, you can see on the IVUS there wasn't a lot of dissection, there was not a lot of thrombus, so neither of those were big.
So the IVL catheter, it does work with very low pressures, does it?
That's right. So you inflate it to 4 atmospheres only.
4 to 5 atmospheres.
Yeah.
So the risk of having severe, nasty dissections is lower than using high pressure balloons. Do you think this makes the procedure safer?
I think it does, and particularly in calcific lesions where you might want to do high pressure, non-compliant post-dilatation of your stent. If you have large dissections, that's often a bit risky. It can lead to perforation. So I think if you haven't caused significant dissection, you can be more confident about doing high pressure post-dilatation as well.
Good. So what was next, Claudia?
Okay, so if we go to the next slide. So this is the implantation of the stent. So it was a long stent, a 3.5 millimetre 48 stent from the mid-LAD back to the left main. And we performed a pot in the left main with a 5.5 millimetre non-compliant balloon. And then we post-dilated the LAD with a 4.0 millimetre and 3.5 millimetre non-compliant balloons up to 18 atmospheres. And we could do that confidently because we hadn't seen a lot of dissection. And performed kissing balloon inflation with the circumflex, and then followed by a final pot in the left main with a 6.0 balloon this time. Okay, and then these were our final angiographic images. So you can see that the stent appears angiographically pretty well expanded. The circumflex doesn't appear to have been compromised. There's not a lot of obvious plaque in the ostium of the circumflex or any obvious dissection. And
before we move to the final intravascular imaging, I'd like to know, Claudio, your opinion on this final angiographic result. Is it, I mean, the flow is great. I assume that the patient was doing much better with less chest pain and a good ST resolution. Is there, let's suppose you don't have intravascular imaging and you want to assess whether you are satisfied or not with this. Which are the variables that you will take into account?
I think for sure I will look for the flow. I think it's a major and important aspect during the acute phase. We don't have any loss of major branch, and the stent expansion seems really nice in two projections. And also the fact that Claudia has focused the image and seen the stent expansion on angio, I think it also can be reassuring in this case, and the results angiographically it's really beautiful.
So you are satisfied, on your opinion?
I'm satisfied, and in this type of case, sometimes you need to look exactly at the level of the distal landing zone of the stent and proximally. You can focus on that, and you need to take decision. If you don't have IVUS, this is also an important aspect. Sometimes you need maybe multiple projection, but in this case, in my opinion, it seems really good.
Okay, and for you, Claudia, is that okay? Is that enough? It's a good result? I don't want to be nasty, but I see there is a little step inside the stent at the point of the emergency of the major septal branch. That this concerns you, or it's okay, you will accept that result, or you want to look at the intravascular imaging again?
You're very picky, Flavio. But yes, I think there is a little step down at the side of that septal, but the IVUS, I think, can tell us whether that's a problem or not. So we can see that distally and proximal to that area, it's well expanded and circular. That little step down's at that spot of bulky eccentric calcium, and so we've got a slightly asymmetrical stent expansion. But actually, when we measured the minimum stent area there, it was 6.5 millimetres squared. So although it's not perfectly circular, I think that's still a very good result. And we could have gone on perhaps to do more aggressive post-dilatation, but that carries the risk of things like perforation, and it really wasn't necessary with a stent area like that. So I think that's one of the important messages. You don't always need to achieve a circular stent at the end, as long as the stent area is actually more important.
I think you are raising very, very important messages, Claudia. We know that the best is enemy of the good, and we have to set a kind of trade-off in between what looks perfect and what works perfect. In this case, there is a little step. It's clear in the angiography, it's clear in the IVUS, but the area of this highest point is more than 6 square millimeters in a mid to distal LAD, so it's certainly more than acceptable. Then there is another concept. Calcium, it's a stone. So you can make fractures, you can push it a little bit, but if you push it too much, it will break the artery wall. So it's always a trade-off in between efficacy and safety. And of course, working low pressure with the IVL balloon makes this much simpler and safer than going with a 4.0, 30 atmospheres to get what? To get 7 square millimeters, and you have the risk of breaking the artery wall and having tamponade and complications. So I think it's very wise to stop at a certain point after you get an acceptable result. Let's suppose you don't like the result. Could you go again with an IVL catheter and expand further the stent?
It is possible. I think it's an off-label use of the shockwave balloon, but it has been done, and I've done it when it's a last resort, I'd say, but it can be very effective because it reaches that calcium behind the stent. So it's best to prepare the calcium first time round before you put the stent in, but if as a bailout, as a last resort, then it can be used inside a stent.
Claudio, do you have experience in using the IVL catheter to expand under-expanded stents?
To be honest, I failed to evaluate the vessel sometimes. I need to be honest, and it can help. But actually, when you are in that position, you realize yourself you failed. You failed because you didn't do imaging, or you failed because you didn't prepare the vessel. But it can be helpful, and actually you can avoid stent thrombosis related to under-expansion. And if you, it's maybe safer than an OPN sometimes. Sometimes.
So you made a point clear, Claudia. It's by the manufacturer. It's an off-label application, but in practical, we know it's the best and the safest way to expand an under-expanded stent in a calcified lesion. So I do it regularly, with no fear of damaging the stent polymer or whatever, and it's certainly the most effective and safe way to expand a stent. What is not necessary in this case, I agree with you that angiographically there is a little step, but the result looks very, very good. Thank you for this very nice case. Now we have still 5 minutes to address the questions of our colleagues. There is a question that comes every time when I see stenting the left main. A colleague is asking, Sadaf Sabir Kiani, he's asking, should I go up to the ostium of the left main when you were putting the stent, or can I stand on the shaft of the left main?
I think if there's disease back to the ostium of the left main, then you should cover that. I think if there isn't plaque right back to the left main, it may be fine to stop short of the ostium. You need to leave enough room in the left main for a pot balloon, so you need at least 6 or 8 millimetres for a pot balloon if you're not going to cover the ostium. So I think those are the considerations. I don't think it's necessary to always cover the osteum.
If you don't have plaque.
If you don't have plaque at the osteum.
What is very important is that you check final state of the stent in the left main and do not leave under-expanded stent in the left main. So it's very important. It will become, I hope it will become a class 1 indication to do IVUS in left main interventions. There are studies ongoing. We still need evidence to put it in class 1A. Today is 2A, which is indeed anyway a very strong indication to have a look with IVUS to make sure that the stent is well expanded, rather than being on the ostium or on the shaft. And there is another question. This is coming from Sahim Arokiame. If you see thrombus and eccentric calcium on IVUS in STEMI, would you rather take the patient off the table and bring him the day after or some days later after you have put the patient on aggressive antithrombotic therapy and finishing the work? Is that something you do, you consider, or you don't?
I think that's a reasonable thing to do. I think if you, perhaps in that situation, if you've restored flow, if you've achieved TIMI3 flow, so that's the first objective in any STEMI, isn't it? So if you've restored flow, it may be safe to put them on, something like a 2B3A inhibitor and then bring them back to the cath lab a few days later. I think that's reasonable, in which case then it may be safer to do more aggressive calcium modification in that situation. If you haven't, then there probably is more risk of no reflow with all of the calcium modification tools, I think, in a heavily thrombotic lesion.
I will tell you, I am a little bit older than you are, and this question has come up in my mind for many years, and there is also some literature saying that this is not worthy. What is important, and what is one of the main objectives of this webinar, is that we make young operators confident when they are dealing with severely calcified lesions, especially in the setting of acute coronary syndrome. So, first thing is opening the vessel and providing good reperfusion. So we are saving myocardium, which means we are saving life. Then, if you don't feel confident in finalizing a good angiographic and intravascular and clinical and everything result, well, you may stop and ask someone to take care of this patient the day after. But what we want is that young interventionalists become confident in dealing with severely calcified lesions in acute coronary syndrome. So what you did, I think it's very clear to show how simply you can manage these lesions with a very nice final result, which makes hopefully a very good long-term outcome for this patient, rather than stopping because you are frightened to deal with calcified lesions. Of course, there are different devices. Rotablation will take longer learning curve to make you confident to deal with off hours and alone with a nurse and a technician. This device has this incredible advantage to make you say confident very easily with a very short learning curve and providing this final result. So I guess that if you have devices like this, and if you are lucky and you can assist your procedure and decision making with intravascular imaging, you can start the case and finish the case with a very good result like the one you have just shown, even if you are not 30 years old operator, 30 years old history operator in calcified lesions, which is probably one of the main goals of this meeting today. So thank you very much, Claudia. It was a very nice, apparently simple case because it was done properly step by step.
Yep.
But of course, if you start with the wrong strategy and you start pushing a stent which is not crossing and creating dissections and low flow, everything could be much worse than that. So I appreciate this case very much.
Thanks, Claudio.
Now we move to Claudio. Claudio, the next case is yours.
Let's play the next case. Thank you, Claudia. Thank you, Flavio. I will just try to present the next case. It's about a relatively young patient, 63 years old, without prior cardiovascular history and past. Our patient presents typical symptoms, and our colleagues screened the patient with a coronary CT that showed moderate and severe calcified proximal and mid-LED lesion with an Agatston score of 960. We'll play the angio. You have both projection, a cranial and a right projection, showing non-impressive coronary disease. You know, it's just slightly to maximum moderate calcification at the level of LAD, proximal, ostial, and mid for sure. The left main seems slightly a disease, mostly in the distal part. And you see maximum 60 to 70% of stenosis at the level of mid-LAD, just the point where the second diagonal starts. This is the second projection. You can see in both images. The angio was done with really low frame per second. Regarding of our radiation protocol, and I think this angiogram is not able to show perfectly all the details of the coronary disease of our patient.
Okay, you are making some interesting questions in this first angiogram. What you said lately, I mean, using low rate frame for filming calcified lesions is not a good idea. Is that what you mean? You need to have more frames per second to get a better evaluation of the severity of the calcification. Is that right? Is that what you mean?
I think depend for sure of the body mass of the patient, but in patients that are a little bit more obese, I think we cannot evaluate all the details as we want to have to plan accordingly a strategy and to achieve
I think it makes a lot of sense. Evaluating calcification on the angiographic fluoroscopic image is always tricky and, let's say, unprecise. So the less frames you have in second, the less precise it will be. So I think it's a good advice. I have never thought about that. We use regularly 15 or 20.5, depending on the type of angiographic device. 7.5, of course, will give you less information, unless you will use intravascular imaging later. But based on this angiography, you have a relatively young patient with chest pain. You did a non-invasive CT showing that there is calcium, so the likelihood of having angina as a symptom, it's getting bigger, but we still have what I consider a rather benign or intermediate lesion. I don't see this as a focal, let's say, using a very old terminology, critical stenosis on the LAD. I'd like to know if you are convinced that this LAD, provided that the right and the circ are okay, is the cause of these symptoms, and these symptoms are really typical ischemic angina.
Yes, perfect question. I think perfect point. I will just address that in the next slide because we go further and we evaluate the functional significance of the lesion. But I just want to apologize to my colleagues and to you both because I didn't put the right image of the coronary right that is perfectly healthy. So sorry for that. I will just proceed. You'll have a rest index of a 0.84 and you'll have adenosine FFR conventional intracoronary administration and it's 0.7T. The wire was placed exactly in the level of the mid-distal LAD. You have just two measurements from this without a pullback. For sure, we can discuss about that, but we have the proof of ischemia in LAD related to this diffuse disease without knowing exactly which lesion it's responsible or culprit for this.
Yeah, it's a long lesion. You have the sensor distal to the second diagonal, and there is no doubt. FFR 0.70 is well below the 75 cutoff. It's not even the 0.80. So now we can say that what the patient is complaining of is angina. So this is an ischemic anterior wall. Now, it's still highly symptomatic. It's class 3, but it's stable. So we have here a crossroad. We know that medical therapy, surgery, and PCI in a stable patient provides at least at 5 to 7 years the same clinical outcome. What is your decision? Do you consider this as a candidate for mammary artery, for medical therapy, or you would try to fix this with a balloon and a stent?
To add something in the discussion, we just calculate the syntax 1 and 2 score for that. You can see also another projection, a spider projection in the image. For sure, we have a syntax 1 of 17 taking into account the calcified lesion and without taking into account the left main or other bifurcation. Proximal and mid LAD, and with the syntax 2 that it's similar for PCI and for cabbage, related also to the 4-year mortality. We have an equipoise between the two approaches. Related to the fact that we have a young patient that is symptomatic with proof of ischemia, we saw that revascularization is indicated in this particular case, and we propose for the patient treatment by PCI.
Good. So I think that it's clear in this case a single mammary artery or PCI yields quite equivalent clinical results and risk of mortality according to the syntax 2. The syntax score is 17, so it's the low tertile of vessel complexity. I think it's a good option for a young patient, highly symptomatic. My question is, do you know enough to start your procedure? You have the CT scan, you have a normal LV function, you have angiographically highly calcified vessel with moderate MLD because it's not a very tight lesion with proof of ischemia on FFR. Are you ready to go with a direct stent in that lesion?
With the direct stent, maybe not, but actually I just wonder myself, I just ask myself where to place my distal stent and exactly how I will deal this proximal and ostial LAD.
And for that purpose, do you use FFR or IFR pullback? Do you use that as an indicator of spotting your stent, or you consider this as a diffuse disease and you go, as Claudia did in the case before, from healthy to healthy with a long stent?
I think it's reasonable to do this pullback of FFR because you will have much more information. But after that, IVUS give us important information related to the morphological aspects and distribution of calcium in the arteries, related to the size of the artery. We can evaluate also after that if we have some stent under expansion and our PCI result. I think in this particular case, we choose the anatomical evaluation by IVUS.
Okay, so you did intravascular imaging on that?
Yes, exactly. It's in the next slide, you can appreciate the pullback of the IVUS. I will describe this pullback starting with the mid-distal LAD. where you can see really different distribution of calcium. You can start with really superficial and deep calcium. We just pass over a ring of calcium, and here you have a nodular eccentric plaque that protrudes. You can see here in this particular image, and also the ostial LED it's involved, and the plaque goes exactly to the left main. You'll see in the next image. You see this was an ostial LED, and this is the left main. But the calcium, it's also at this level, and that make us really think about our strategy, where and how to tackle this really diffuse and severely calcified disease with different aspects. We have concentric and we have eccentric severe calcification and multiple spots, at least 2 rings of calcium, and also an important nodular calcium at the level of ostial LED. We go a little bit further. We just try to select again the spots, the left main. Here you have a residual diameter of 4, and you have a ring of 180 of calcium. It's a thin sheet, but actually the minimal lumen area was 10.75.
In the left main?
Exactly,
Okay.
in the distal left main. When you go on LED, you see here the nodule of calcium. It's a 3.5 artery, and I have the impression that really the thick of the sheet of calcium is really important here. We confirm the size of the artery. We go a little bit distal, and here we have a ring of calcium at the level of LED. But what we notice here, the area is 3.79. And we thought that, okay, we have enough space maybe to tackle this calcified lesion based on a balloon strategy. And that was...
So based on this angiogram, which shows you a long calcified lesion without a very tight stenosis, but with the IVUS that is showing a wide array of different manifestations of calcium. You have 360, you have 180, you have some nodular calcification. I have seen something like a little bit of a speckle of calcium in the ostial LED, despite the lumen it's quite large. It's not large enough because you have a distal FFR which is 0.70, so of course this is impairing the distal perfusion. But based on all this information, because you also have the non-invasive CT scan confirming that this vessel wall is very thick, very tough to dilate. Which is your first approach?
We thought that we can modify these lesions, calcified lesion, based on a balloon, and we thought that maybe we can go directly with an IVL, but sometimes IVL don't cross, and I think it's in our opinion it's always better to touch the vessel with a small balloon and to predilate the lesion before taking the IVL catheter.
Okay, is that something you do also, Claudia, before trying to use IVL? To pass with a smaller balloon?
Yes, in most cases, usually something like a 2.5 millimeter semi-compliant.
Okay, let's suppose that you are planning to do rotational or orbital atherectomy. Would you still use a balloon before?
Yes, often. I don't think there's really any downside to doing that. You're unlikely to cause big dissections with a 2.5 millimeter balloon that would then make you worried about using atherectomy devices.
Okay.
So I think it's a good way of sort of testing the vessel a little bit and also creating a bit more space for delivery of subsequent equipment.
Well, here it's curious because your IVUS probe did cross. So as we said, there is not a very tight spot, but the balloon 2.5 did not. So it's an intermediate difficulty in between whether to go. The first question I did was very provocative. Would you go with direct stenting? Well, you said very gently, I wouldn't. I'd say never. You should never go with a direct stenting when you see calcium in the angiographic image. This is the first recommendation we have in the European consensus document related to calcified lesions. So then you try the balloon, which is what most of us will do, and the balloon is not crossing. So this is a good message because probably the IVL will not cross. And so when you have an uncrossable lesion, what is your next choice? It's a smaller balloon or it's a different device?
To be honest, it was a surprise for us also. And actually, we had a little bit of chance because we tackled the case from the beginning with a rail tracking approach, a sheetless 7 French guiding catheter. It's normal habitude in our center. It's not about related to this case. And after not being able to cross with the lesion, we just think about what to do next. We place a body wire for sure, and instead, despite the body wire, we still has difficult to cross. And we thought about an algorithm, and in this algorithm, the guide extension I think play an important role. And after that, maybe to use a low-profile balloon could work. And in some IVL case, we use a lot of supportive wire, like a Grand Slam. It's really powerful. It brings a lot of support, and you can deliver the devices easily. And the last resort, maybe it's rotational atherectomy, but it's a left main, it's an LED, it's a young patient, an elective case. We are a little bit afraid of no reflow and complication in this case. And we need to discuss about that before proceeding so easily with high-risk strategies like rotational in a left main, heavily calcified and diffuse disease.
You are right, but I tell you, I mean, anything you do without a good lesion preparation with something like rotational atherectomy, putting supportive wires, putting extension catheter, will ask you to push. You know, our work is delicate. I mean, the more strength you use, the more complications you have. If there is a way to make this case simple, is to polish a little bit the internal surface of this vessel, despite it does not look so tight. So I would go with rotational atherectomy, definitely.
Okay, but for doing that, maybe we need to retrieve all the wires we put. We need to replace
a dedicated wire.
Sometimes we need to use a microcatheter. In this case, it was really fast wiring with a floppy rota wire. And we were able to proceed with a rota burr of 2 because we have a Medtronic guiding catheter that allowed a 2 burr. We are in 7 French, I just remembered to you. And after 4 runs and 66 seconds, 50 seconds, we need to really maintain a short run of rota ablation. We had the luck that the rota cross, not for sure to completely to mid and distal LED, because remember it's a 2 rota burr, is pretty large, and we didn't see any ECG modification. It was really fast. But we had some issue because the rota burr of 2 crossed so easily at the level of the ostial LED, and we tried to do a small tip on tricks and just to change guiding position just by retrieving a little bit, and actually we avoid, in a way, not completely for sure, the wire bias. This is a problem with rota ablation. When you have so much space, even with 2 or bigger burrs, it will just fly next to the nodule and will not touch exactly as we want this nodular calcification.
So this is rotational atherectomy. Let's see what happens, because normally after rotational atherectomy, angiography changes a little bit. It's very disappointed because you shouldn't expect to see a very nicely open vessel. I think Ivus will tell us how effective this preparation was.
Exactly. We didn't inject. We use IVUS to assess the result of rota. And you see at your left, you see the pullback of IVUS after rota. And in the mid part of the screen, you see the image, a fixed image of the level of the mid LED before rota. And on your right, you'll see exactly the reverberation of after rota ablation. A second freeze image, you can see here 2 fractures at 9 and 6 o'clock at the level of a ring of calcium. And here you can appreciate also a small fracture. For sure, it's not spectacular as we expect after a large burr. We thought that we'll have really a much more effect, but we need to take consideration we have deep calcification, and rota maybe it's a device properly designed for superficial calcium and to create space to deliver material, but deep calcification is sometimes...
Yeah, you are right. So the answer to understand whether it was effective is to see whether now you can cross with the balloon. Go.
Exactly. Here we can cross with a balloon for sure, and after that we go exactly with a big balloon.
4-0. So 4-0 crossed after Rota.
Easily.
Before Rota
Easily.
2.5 didn't cross.
Exactly.
So it did make the work.
Exactly.
Okay.
Exactly.
But your balloon looks a little bit underexpanded despite the high pressure, is it?
Exactly. You can
Yeah.
see here exactly waist at the level of the left main ostial LED, but the stent enhancement help us a lot, you know. And because we cross with a 4 balloon, we can take right away the IVL catheter.
Good.
Because we are really incomplete in our lesion preparation. Using the stent enhancement, we can place the balloon really well, and we need to do this effort because actually to gain the maximum effect of the IVL, you need to place correctly, and you need to know exactly your balloon. You have 2 millimeters distance from the emitters to the distal part, and also 4 millimeters between the proximal and the second emitters. You need to know exactly this particularity of the balloon to track the maximum effect. You have here exactly in the right the map or the shape of the sound waves to position well your balloon in this calcified lesion.
And you always stay low pressure, is that right? 4 to 5 atmospheres?
Always in the left main, maybe, you know, we are
IVL?
limited on the size. We have 4 millimeters balloon. Sometimes I go to 6 just to have to touch the wall. It's really important to touch the wall. This is really an important message. We need to be in contact with the wall to deliver the energy.
Good. Because I make this question because our colleagues are asking, would you have considered, for instance, using cutting balloons or OPN balloons?
I think I'm a little bit afraid sometimes ostial LED to have some dissection that protrudes to the circumflex or towards the left main. I think it's a much more safer to use IVL in this type of cases.
Okay.
It's more predictable, and also you avoid barotrauma with this type of balloons.
And so you repeated IVUS after that. I'm curious to see.
Exactly. It's an important image because it highlights exactly the effect of IVL in combination with Rota at the level of the nodular calcium, and you see multiple and deep fractures. You remember that the Rota was not able to do that, and after IVL, everything changed. Everything changed, and we have the feeling that the compliance of the vessel changed. Just a slide, a theoretical slide coming from the OCT sub-study in comparing the patient role in DISRUPT CD3 trial, and we see actually in eccentric lesion IVL behaved really well, and we don't have a lot of difference between eccentric and concentric lesion regarding to stent crossing, stent delivery, and stent expansion, and also clinical outcomes. IVL seems really effective in eccentric and nodular calcium lesion.
So what did IVL added after rotablation, in your opinion? What makes this difference?
We were able to crack actually the calcium at a deeper level.
The deeper calcium, but rotablation allowed you to go with the balloon. So this is a clear case in which it's not frequent, but sometimes you need both.
Sometimes you need both, exactly.
Okay.
And you get...
So are complementary in this case?
Sometimes are complementary, yes. And the effect it's spectacular.
So now you go with the stent, you are ready to go. There is a question from Francisco Lavarra. He asks, in this big lesion, would you consider putting 2 stents? I mean, a smaller one, 3.0 in the LED and a 4.0 in the left main, so you don't stress the proximal part of the stent to go 4 or 5 or 6 atmosphere for the 3 stent?
Exactly what we did also.
Okay.
It's a good comment. Exactly, if you see in the slides, I cannot see the slides here. Sorry. Exactly, okay. we place first at the level of mid LED, proximal to mid a 3.33 stent. After that, we realize the kissing balloon with the diagonal because it's a little bit pinch. We do a pot, and after that we place the Megatron that is 4x28 ostial left main towards proximal LED, and we end up with a classical provisional step approach, a pot and kissing with a circumflex, like in Claudia case. We can proceed. I think it's important. We need to use IVUS at every step of the procedure, before stenting and also after placing the stent. And we assess actually the expansion of the stent that we consider really optimal. I let you see the pullback if we have time.
Yes, we do.
And we didn't see under expansion zones. The stent was really nicely expanded, like nicely opposed also, and not completely circular for sure. We didn't expect that even after treating extensively the calcified lesion with rota IVL and non-compliant balloon and high pressure. But it's pretty nice, and we had a decent minimal stent area. We know that is the most important trigger to define outcome for the patient. And 14.28, I think it's a good minimal stent area at that level. And here we have also for the proximal LED, 12.89 of minimal stent area. We consider that acceptable, and you can appreciate the last two projections, and we end up with these results. This is an angiographic final result of this case.
Claudia, do you like these IVUS and angio results?
I think it's an excellent result, and I think you achieved that by using a couple of different tools, and probably wouldn't have got such a good result without the combination, I think. And you've got very good stent expansion throughout what was quite a challenging case.
So at the beginning I said you are both young and gifted operators, but I have to add that you are also lucky operators because you work in this Occidental world full of technology and resources. But let's suppose we don't have IVUS and we cannot check so accurately as you did this nice, I'd say, perfect final result. How would you manage to decide that you are done, that you don't need to treat this vessel any longer if you just have a good or regular angiographic equipment? Is there any trick you can share with your colleagues?
Well, I mean, I think certainly, as we've said before, in a left main case, IVUS should be mandatory. Yeah. I don't think you can, really ever feel that you've done, a great result without checking the minimum stent areas. But, certainly checking orthogonal angiographic views gives you some idea about more symmetrical stent expansion, as you might have quite underexpanded stent in one view. So that's one way.
Important to have an orthogonal view. And Claudia, you mentioned the stent bars. This is let's say a poor man's IVUS system, something like that?
I think it's a pretty nice device. It cannot replace IVUS for sure, but if you don't have IVUS, I think it's a must. I think it can help you a lot. And to be honest, we do a lot of stent enhancement on the balloon, but with the balloon inflated. And we see exactly the expansion. But you need to also take in consideration your experience and your tactile feedback. And if the material don't cross or if the material just stopped, you need to understand that the place where your balloon stopped, maybe it's a place of maximal resistance, and you need to work exactly on that spot with some specific therapy. But okay, I don't think for sure that IVUS can be replaced so easily.
Good. We are coming to the end of this session. I think that we have gone through most of the aims that we have proposed from the beginning. I just have a final point to discuss with you, which is the need to treat these vessels in the acute coronary syndrome setting. I mean, these patients were selective, Claudia. Exactly. You had all your team, you have your nurses, your technicians, and you have gone through a learning curve to take the rotablator out of the shelf and to use it properly. I'd say quite aggressively, because indeed a 2.0 bar in an LED, it's an aggressive decision, which was right, because the MLD was quite large. So otherwise you don't do nothing. And in this case, you actually prepare the vessel for the treatment with balloon-based technology. So would you share with me the concept that all the beginners should be involved in learning how to use all these kind of different devices? Because it will happen that you will have to treat a patient in the night or in a Sunday, and you must provide a good result like this one.
I don't think in today PCI you will have just IVL operators and rota operators. You need to have the freedom to choose and to go from one to other strategy. The patient will need that. It will not need maybe today, but will need tomorrow, and you will find the patient that maybe will have uncrossable lesion, etc., etc. I don't think we need to separate the physician in IVL or balloon, just balloon operator, or just stent operator, or just STEMI operator, and etc., etc. I don't think we need to define our approach based on a device, and we need to take to be complete. I think imaging it's important, and the therapy IVL and rota maybe needs to be need to be trained.
Great.
Exactly.
Claudia, you have the privilege of the final words.
Well, I think you said it well. I think everybody does need to try to learn all these techniques, and it's best to learn in a lower acuity setting, perhaps with a colleague, so that then when you're by yourself in the middle of the night, you have the skills to be able to tackle calcific lesions, because we're seeing a lot of calcium. There's rarely any simple lesions anymore. So everybody, these calcium modification techniques shouldn't be the reserve of complex operators.
Great.
They should be available to everybody, I think.
Good.
Yep.
That's good. We are perfectly on time, but I will take 10 seconds to reply to one of the last questions from our colleagues, Ahmad Saram. What about in-stent calcified lesions? If you cannot expand a stent, the best way, the safest way to do it is use IVL. Although it's an off-label situation, but it's certainly the safest and the most effective. That being said, I want to thank my two colleagues for being here. I really enjoyed staying with you and learning from your experience. And as I said, this is experience from young people, because using the right technology and the good technique, you can treat complex calcified lesions in a simple and effective way. Thank you very much. I hope you enjoyed this session. I look forward to having you again in a PCR webinar in the near future.